Next up, we have Dr. Adam Kaplin, who is the Chief Consultant for the Multiple Sclerosis and Transverse Myelitis Centers. And he has dual appointments with the Department of Neurology and Department of Psychiatry. And he will be talking about neuropsychiatric aspects of transverse myelitis.
Great. Thank you so much. I thank you all for coming here. I know it's not easy to get up and out and organize and all of that, so thanks for your effort. You know, I will tell you that I had the opportunity to go to England about a month ago, and they lack the centers that we have here. So this is the first TM center and one of the few NMO centers. I don't know actually if there are any others, but in any case, so we're very fortunate to have this organized here. We're also very fortunate to have Carlos Pardo and Daniel Becker here because it is the World Cup is going on. And just to give you an idea of the sort of passion that's involved in this kind of games, it reminds me of a joke, which is a young fan arrives in his seat in the World Cup and he looks next to him, it's an empty seat, and next to that, there's an elderly gentleman, and he says, you know, these seats are all sold out. How come this person didn't show? And the old man says, yes, that was, my wife was supposed to come with me. We've been to 5 World Cups together, and she passed away recently. He said, oh, that's terrible. Couldn't get a family member to come, though? He said, no, unfortunately, they're at her funeral. So, so we are fortunate to have them here and their commitment. My job is to sort of give you an idea of sort of the above the neck effects of these illnesses. You all should have a handout. If you don't, one can, I'm sure that there are some leftovers, but so you don't have to jot anything down, and I will go a little quickly. So again, Carlos gave a wonderful introduction. Transverse just means lying across. Myelitis, inflammation of the spinal cord, so that's what we're talking about. Now, MS obviously isn't the same, but it is worth noting that they both involve the barbarians have gotten across the blood-brain barrier. The immune system that should be fighting off infections has now, for some reason, decided to attack the spinal cord. And so much of what we know comes from the research that's been done in MS. So I will show you that in fact, many of the things that we've been doing in TM and NMO is to sort of catch up to what has been done in MS. But essentially, I'm not going to go into any detail because I think, some of the groundbreaking work looking at, vitamin D and its role and the genetics that are potentially involved in the immune system activation, I think we'll be hearing from later because some of that landmark work was done right here at Hopkins. So just to let you know, there are many insults to the brain that can lead to depression. People sometimes say, Adam, you're a psychiatrist. Why are you, living over in the TM and NMO centers? And I say, why did Willie Sutton rob banks? That's where the money is. So if you want to know where where the depression is, originally MS is the Michael Phelps, the #1 winner, gold medal winner of being associated with depression. So more depression is associated with TM, now we know, and MS. Than is any other condition. So to give you an idea, that means following the diagnosis, the lifetime prevalence of clinical depression, and I'll explain what that is in a second, is 50% at any given time. 1 in 4 patients suffering from multiple sclerosis is suffering from a depression, which is 5 times the general population. I will also touch on this, which is that there's cognitive impairment. Fortunately, it tends to be a milder cognitive impairment for the vast majority of people, sort of word finding problems, sort of that word on the tip of your tongue, you can't remember what it is, or walking into the kitchen and forgetting what you came there for. I know that's never happened to anybody here, but anyway, we'll get back to that. So what is clinical depression? It's having 5 of 9 symptoms or greater than 2 weeks, and those symptoms are decreased sleep. Often it's early morning awakenings. Many people at night are thinking about all the stuff they have to do the next day, hard time falling asleep, but that waking up early in the morning and not being able to fall back into sleep, or excessive sleep, just sort of not being able to get out of bed, not finding any energy. People's get up and go has gotten up and gone. They have lost their interest or pleasure in things. Feelings of guilt or worthlessness that often gets in the way of people getting the treatment they need. Oh, I don't want to burden anybody. Just, like my Jewish grandmother, I'll just stay here in the dark until you call. So that feelings of guilt or worthlessness, low energy or fatigue. And again, that can be difficult because that comes along with autoimmune conditions. Low mood, but remember, mood is just one symptom that you don't even require in order to make the diagnosis of depression. What I mean by that is a lot of people think, well, gee, I went to this movie last night. It was so, depressing that, I came home and they don't mean that they came home and had to take Zoloft. They mean that they were sad, right? The movie was depressing is the movie was really sad. Sad is just a symptom. Like cough is a symptom of pneumonia, but not every cough is an indicator of pneumonia, and sometimes you get pneumonia without a cough. Same thing with sadness and depression. You don't even need to have sadness to make the diagnosis. Concentration problems, appetite, either comfort feeding where you just can't get enough because that reward system in the brain isn't stimulated enough. For women, it's often chocolate. Men, it's often salty foods like Doritos and the like, but obviously that is not gender specific. Or weight loss. Food doesn't, have any taste or flavor or any reward, and people lose a tremendous amount of weight. What's called psychomotor retardation or agitation, meaning that people who know and love that person can tell they're not their normal bubbly selves, however bubbly they were to begin with. And then thoughts of death. If you have 5 of 9 of those symptoms for greater than 2 weeks, at least one of which is decreased interest or decreased mood, you've bought yourself the diagnosis of a major depressive disorder, a clinical depression, if you will. And that is the more symptoms you have, the more likely you are to respond to treatment. So again, I'm just giving you a survey here, but let me just tell you that we know in MS that it's not, gee, you'd be depressed too. And if you had this disease. In other words, it's not just the result of failure to cope with this illness or this disability or this life under altered circumstances. And, the best evidence I can give you is that those people who walk around where you can't tell that they have MS or can't tell that they have TM are often, and they have depression, are often so debilitated by the depression that they say, and yet they don't get any sympathy, that they say, I sort of almost wish I dragged a leg so people could see what kind of suffering I'm going through. So that gives you some idea that it's not, if it occurs in people who are, only in wheelchairs or on ventilators, you'd say, well, that's just having a hard time adjusting. That's not the case. It doesn't actually correlate with their level of disability. What it correlates with is periods of inflammation. Activation of the immune system is what causes it. But remember, that can go on without having any knowledge of that going on. In fact, when we did some experiments where we did serial lumbar punctures in people who had transverse myelitis, for instance, I would get called about an emergency value, and it would turn out that some of the patients with TM, periodically, when I would get called, had white blood cell elevations in their spinal cord. And that was following the attack. They had monophasic, only one-time transverse myelitis, but again, suggesting that there is some ongoing continued inflammation, certainly in some patients. So again, it's not a personality flaw. It's not a personal weakness. It is the result of inflammation happening in the brain. So this is, are you getting enough oxygen? What it reminds me of is 2 things. First of all, that turns out depression is the #1 correlate of quality of life for people with MS and TM. By the way, it's not that I am leaving NMO out. It's just that there's not as much research done in NMO because it's even less common than in TM. And Michael Levy sort of has joined us and brought this center to us more recently. So much of what I have to restrict myself to is the knowledge we have about TM based on the research that we've done here with the longer center that Carlos has been involved in pioneering. But it's the #1 correlate of quality of life for people with MS. And I'll prove that to you in just a second, but it's more important than whether you have fatigue or cognitive impairment or, level of disability. Second of all, it reminds me that it's the #1 correlate of quality of life, not just for the patient, but for their significant others. And what I always like to remind people is, if you're traveling on an airplane and the oxygen mask dropped down, and you're traveling with small children or people who need help, who do you put the oxygen mask on first, yourself or your loved ones? Right. So for those of you who are sort of quizzical about that and maybe even got it wrong, let me explain why. There's about 20 to 30 seconds when the oxygen gets sucked out of that plane before you lose consciousness. And if you're there struggling with your loved ones or your children to put that oxygen mask on, they're going to pass out, you're going to pass out, nobody's going to make it. If you put the oxygen mask on yourself first, you can struggle with them if you'd like, or you can time it 30 seconds. They'll be asleep right next to you, waiting for you to put the mask on them. But either way, the important thing to know is that what almost universally happens is to those people whose bodies don't have the illness, but who tied their wagons to those people, the significant others, there's this sense of, oh, I couldn't possibly go out to the movies without my partner. I couldn't possibly go to that social occasion. I don't have time to go see the doctor myself. And what you're doing is you're actually ruining the whole situation for the two of you, meaning that if you don't recharge your engines, you're not going to be able to be there. If you don't ensure that you're getting enough oxygen, you will not be able to be there for your loved one. So for those of you whose bodies are affected with these illnesses, please push your significant other out at least once a week and say, please go recharge your engines, do what you want to do, so that when you come back, you'll be even more ready to, go through this with me. So again, the proof I promised about how depression's the number one correlate of quality of life is that 30% of people with MS will have thoughts of wanting to kill themselves, 10% will attempt suicide. And if you're willing to commit suicide, clearly you're willing to throw everything away, right? There's nothing in your life that is more important than the depression if 30% of the people are willing to say, I'll trade everything in for this. So again, it's 7.5 times the general population. It's the third leading cause of death in patients with MS. In the first 5 years of the TM Center, the leading cause of death in the TM Center was suicide. So again, because not many people should die with TM or from TM, and so it was really the depression. And again, this just shows you, I'm not going to go into the details except to say that, the blue here represents mild to moderate depression, and the purple represents more severe depression. And when we screened the first group of consecutive patients in the TM and MS centers, what we found is that the depression was just as high in TM. In fact, it was higher in terms of severe depression than even the MS patients. So that means that TM is much like MS in terms of having this depression. So here's the important thing to know, though. Not only does MS and TM cause depression, but it turns out that having depression is bad for the TM and MS. Certainly we have data that it's bad for the MS. And the data we have includes things like, if you draw blood from patients with MS who are depressed, and you then expose their white blood cells in their blood to myelin, they're twice as aggressive in releasing these sort of angry cytokines, interferon gamma in particular, that tends to go up before exacerbations. They produce twice as much of an activation in the depressed patients as those who are not depressed. You treat their depression, and in only those whose depressions improve, their immune systems come back down to the normal levels. So again, suggesting that treating the depression may be one of the things that is important for treating the MS and presumably the TM as well. So that's what we know about that. We also know chronic stress, and nothing is chronically stressing like being depressed, is associated with worsening exacerbations, worsening number of lesions. But what is interesting is that recently we've had a better understanding that the same medications we use to treat depression, so this is Prozac in this study, a double-blind placebo-controlled study, that's the best kind of study we have, of patients with MS who were not depressed. And then they put those patients and they waited 24 weeks, and you can see white means, and the doctors didn't know whether they were on a sugar pill or Prozac, and the patients didn't know. So there was no bias introduced here. And after 24 weeks, you can see that those people who were on Prozac did not have significant number of new lesions, and those people on placebo did. And those of you who are science geeks like me want to know what was the p-value, 0.02. And just as an example of one of the measures, those patients who were on Prozac who had no new lesions were 63%. Those people on placebo who had no new lesions were, I can't even see it from here, 26%. So that's less than half, okay? Less than half of the patients on the placebo had no new lesions, suggesting, hey, turns out these SSRIs are helpful. Now there was a large study called the FLAME study that looked at patients who have had strokes. Again, another neurological insult where there's injury to the nervous system. And those people who were put on Prozac immediately after the stroke had better recovery of their function afterwards. Again, suggesting that these treatments have beneficial effects. So everybody knows that what added life to Coca-Cola was what? Cocaine, right? It's all of you nice to not say that, but you know that. It was cocaine. Okay, what was the Up in 7-Up? Caffeine? Actually, no, 7-Up doesn't have caffeine, but it's a good guess. What the Up in 7-Up was lithium. Turned out that lithium, this was lithiated, same time there was cocaine in Coca-Cola, there's lithium in 7-Up. And in fact, it's sort of interesting because maybe you can see this on there. I have to get up here in order to read it. Maybe I'm just getting a little... So this is the original, advertisement for 7-Up, and it says, for hospital or home use, and it says, dispels hangovers, thank you, takes the ouch out of grouch. I just love that. So they clearly knew that this was mood elevating and the mood elevating effects. But what they didn't know, and again, this is sort of keep smiling, freshen up, it really was an upper, right? Lithium is an antidepressant. So why do I bring it up now? This is what's traditionally thought of as the model of MS. Almost all of the drugs that we have for MS had to go through this animal model, which is called EAE, experimental autoimmune encephalomyelitis, except I will tell you this is probably a better model of TM or potentially even NMO than it is of MS. This particular model here, which is where they get one single lesion, it's always in the spinal cord, and then they have, they drag their legs, and then they either recover some function or don't. So this, in EAE, if they gave these animals EAE, which is the animal form of MS, and they had lithium, they didn't get sick. This shows that they had increasing levels of disability, where 3 means they were dragging both their back legs. And then if they waited until they got sick and then they gave them lithium, they had better recovery here. This shows that when they gave lithium to a different model where they have exacerbations like happened in MS or NMO, when they added the lithium, they stopped having the exacerbations. When they took the lithium away, they started having them again. And you can see it clearly had an effect. So I can't show you data to say that this actually helps patients with MS or TM, except, and I know it's hard to see this unfortunately, but the stars here, I can show you mood. So I can show you that the stars represent where I started lithium in people who had that roller coaster ride kind of moods, and their moods going up and down and up and down. And you can see that especially here, you can see mostly down, and then it sort of stabilizes. But in all of these patients, this up and down got better with lithium, or they just had antidepressant effects. By the way, just to let you know, this you can access with a free online technology called mood247.com. That's MOOD, the number 247.com. That is a way that you can sign up online. It keeps track of your, it's sort of an electronic diary online, and it sends your phone a text, not an app. It sends your phone a text, but it's all based on signing up online. So here's the conclusion. The conclusion is that we know there's a relationship between depression and MS. And we know that based in part that lithium and SSRIs are both good for depression, and I showed you the evidence that suggests they're good for MS. Turns out natalizumab, which blocks the inflammation, this is Tysabri, not shockingly, since MS, oh no, you're kidding me. I'm 16 minutes in. I have it right here. 15 minutes. Yeah, so you guys are going to have a hard time with questions today, I can tell you that. So so you can see the inflammation here causes MS, and we showed that Tysabri actually has antidepressant properties. So real quick, because I want to get to the TM-specific data hot off the presses. So it turns out, again, I told you that MS had cognitive impairment, but it wasn't really appreciated for 115 years that MS had any cognitive impairment, because at the level of, hey, how you doing, it's not detectable at all. It tends to be mild. So what do we mean by cognition? Well, learning, speed of processing, being able to think quick and multitask, as well as verbal fluency. Again, that's the word on the tip of my tongue and I can't get it. So we went to a camp myself and Kristen Ron, my collaborator, Camp for Kids with TM. And then Kristen ran around with this tablet and did cognitive testing. One day we might do that here for a conference. And what was sort of shocking to us is this was the perfect comparison group. We looked at the kids who had TM and their siblings who were being brought up in the same stressful environment, parental-wise, they shared genes and the like. And you could see the star means that highly statistically significantly, those kids with TM had slower processing speeds. They had cognitive impairment. And the moms had been telling us for years, following the diagnosis of TM, my kid sort of got this ADHD-like phenomenon, and they weren't getting any help in school. They were just saying, this is just a spinal cord disease. Why do you need any extra time in your tests and the like? And it's not just a spinal cord disease. And what was even more interesting to us is that you could see this just means there was a very high correlation. This is the 3 tests that were actually run. I only showed you the data from the reaction time, but the 3 tests correlated very highly with their age. So now we actually have a way of running around, and we're going to run around with Janet Dean and test kids in Kennedy Krieger and see if those people who had some kind of cognitive impairment from TM or concussions or what have you, if they fall off this curve based on their cognitive performance, does that actually correlate with functional significance? So we're going to have occupational therapists that are really good at assessing function run around and do that. So I didn't want to leave you with the idea that, gee, there's nothing good that can come from knowing this. First of all, there is something good, which is you may want to know that you want to make sure that you give yourself extra time to do, things that are cognitively requiring. Do them in the morning when you're less fatigued. But basically, just real quick, we did another set of studies looking at people with MS, and rather than look at the water, this MRI just looks at water in the brain. But you can actually tune it into different chemicals in the brain, and we tuned it into this one chemical called NAG, N-acetyl-aspartyl-glutamate, that won't be on the test. But we just saw very high correlations you can see between their performance on their paper and pencil tests of cognition and how their levels. The lower the levels, the worse their scores. That was only NAG, not the other chemicals we looked at. So then we couldn't increase NAG levels with a drug in humans because there's no drug to do that yet, but there is a drug that can do that in the animal model of MS. And I know it's hard to see. This little critter went directly for the hole. His path efficiency was 75%. This critter went to the wrong hole and then came over here, which means by day 4, these animals were learning twice as well as these animals. And it wasn't just twice as well. It actually turned out, and again, I'm not going to go into this in detail, but this drop shows the forgetting that these animals had on day 3. By day 4, the blue shows you the EAE animals that are getting the drug that increases NAG, and the black shows you the animals that didn't even have MS. They didn't have EAE. And you can see that those animals with EAE that got the drug treatment are doing just as well as those animals without MS. So it had a dramatic improvement. I can't show you the wonderful study that Dr. Becker did with me looking at scuba, because I'm going to get pulled off. But let me just tell you that the bottom line is that we did show you can reactivate the spinal cord in people who have just traumatic spinal cord injuries. And I believe Dr. Becker is working on a follow-up study raising funding to do patients who have autoimmune conditions. So it turns out that there are ways of reactivating the spine, the circuitry that already exists there. The reason why you can cut the head off a chicken and it'll still run is because all the brain does is say go, and all of the walking is coded into the spinal cord. Turns out scuba activates certain chemicals that end up reactivating this. So that's exciting. People have done this with electrical stimulators and reactivated the spinal cord. So I just want you to know, I think the 2 most exciting areas are stem cell work, such as the work that Dr. Levy's doing, and also spinal stimulators and maybe pharmacological activation of this part of the central nervous system. And I think if we can combine those 2, we could probably restore a lot of function that has been lost. So the last thing is I just wanted to show you this, which is this is Viktor Frankel, also someone who hung out in both had training in psychiatry and neurology, and he believed that this crazy idea that just like we are programmed to want to eat and programmed to want to have sex and programmed to want to have these basic human needs and be loved and communicate, one of the basic human needs is to find purpose in life. And that sounds sort of, gee, that's really touchy-feely, except that 50 years after this guy had introduced that idea, people began to look at this. And what this shows you is those people who had a high purpose in life at the beginning of this study, they followed them for 6 years. They had mild cognitive impairment, pre-Alzheimer's disease. And what you can see is that at 6 years out, they were 2.5 times less likely to have progressed to Alzheimer's disease if they had a high purpose in life score than those people who didn't. Now, there's nothing we have that has shown this kind of differentiation between those people who go on to get Alzheimer's disease and don't. And you might say, well, maybe those people just had good brains, right? But it turns out that's not the case. What this showed is that the number of lesions that these patients had in their brain, okay, and whether or not they had cognitive impairment, decrease in their cognition, depended more on whether or not they had low purpose in life, in which case a few lesions caused a significant drop in their concentration, versus if they had a high purpose in life, they could have a lot of lesions and no cognitive impairment. So it seems to protect people in a significant way. I wasn't there, but Daniel Becker took a bunch of patients who are paralyzed skiing. I did this last year, and it showed that they had a significant improvement in their purpose in life. So get out there, do a lot of stuff. It can make a big difference. I'm not going to go through this, but I do want to make sure that I thank Kristen Ron, Barbara Slusher, of course, Daniel Becker, who's collaborated on all the spinal cord stuff, and my posse of people who help, and thanks for your time. Okay. Yeah, it's MOOD, the number 247.com. I sold this.
Okay, so Wendy's going to get to 2 questions if we have 2 questions.
I'm going to be sticking around, so during the break, and so normally people want to ask these questions at break anyway, but I'm happy to answer them now.
Hi, thank you. I was just wondering if, so is Prozac like the frontline choice for treatment of depression? Or
Yeah,
do you
so
consider
Prozac turns out to be the drug, the first SSRI introduced since 1988, and as a result, it was generic for all of these studies, so they didn't have to, pay a company a lot of money to do these studies. It probably is the case. I can tell you from the research that we've done, looking at how good these are at protecting neurons in a dish, all of the SSRIs work well.
Oh, okay.
So there's nothing magical about Prozac,
Right.
at least based on our studies looking at the neuroprotection, the ability to preserve neurons in a dish. And so I don't think Prozac is magic. For those of you who say, gee, I only want to use a drug that has, proven research, then Prozac has the research done, but it's almost certainly an effect of the serotonin effects of the
Sure.
drug.
This is mainly directed to the first doctor, but you can also chime in if you'd like. Quick question. What is the average time between entering the emergency room and being diagnosed with TM?
I'm going to have to turf that one.
I'm going to actually defer that question because our second question is already with the microphone.
Oh,
It's a
so you're
good
gonna disregard
question. I
me?
think we will have experts who have looked. I mean, this is I can tell you that clinically, patients most often, when the center was first started, almost all the patients would come in and said they were told that this is just in their minds and they're crazy and the like. So the answer was a long time, like post-discharge from the ER. I think it's getting better and better, but I'm not an expert to be able to answer that question. Is there another question about what this? Yes.
Question
Thank you.
for Kaplin.
Based on the research, using SSRIs and lithium, is that now standard practice before patients even complain of feeling depressed? Or
Yeah, so that's a great question. My mentor used to say all medicines are toxins, they just have beneficial side effects. So all medicines have both risks and benefits. So having said that, I will tell you that nowadays, because of the FLAME study, certainly, people who have had trauma, usually when they go to an acute rehab facility, often they're going to be put on an SSRI because of the large Lancet multi-center study showing that it improves recovery. So being on an SSRI is probably standard of care for an acute brain injury. But there are potential side effects. I mean, these drugs cause Sometimes they cause sexual dysfunction. People say, oh, they have mild side effects. Unless, assuming not being able to have sex is a mild side effect, then that's mild to some, more severe to others. So, again, they don't all do that, but there are side effects associated with any medicine, and you always want to ask your doctor and sort of have a risk-benefit assessment as to whether that's going to be most beneficial or not. Okay, great. Thanks.
Thank you, Dr. Kaplin.